Hello, I'm Julie Gayle. I'm going to be discussing contraception. I'd like to start off with a video that gives a brief history of contraception. So as you can see in the video, we have come a long way. Still, here in the U.S., over half of pregnancies are unplanned or unintended. Of those unplanned pregnancies, half of the women do not use any type of contraception, whereas the other half become pregnant from some type of contraceptive failure. This is why it is important for us as healthcare providers to be knowledgeable about contraception and be able to educate our patients. When we talk about the efficacy of contraceptive methods, we must consider both the inherent effectiveness of the method itself and, of course, how consistently and correctly it is used. You'll hear us mention typical versus perfect use, and you can see by this slide, out of the unintended pregnancies, less than 5% occur with perfect use of the contraceptive method. In 2010, unintended pregnancies resulted in $21 billion of healthcare expenditures. Unintended pregnancies increase the risk for poor maternal and infant outcomes. They tend to occur in high proportions among adolescent and young women, women who are racial and ethnic minorities, and women with lower levels of education and income. The most common contraceptive method is the oral contraceptive pill. As previously discussed, most unintended pregnancies result from typical or incorrect use of the contraceptive method. That's why it's important for us as healthcare providers to implement strategies to educate the women and assist them in choosing the most appropriate method for them. Contraceptive has many healthcare benefits, which we'll talk about some of those. It can lead to lower rates of induced abortions and improve their overall socioeconomic status. And this could be in the case where they're allowed to finish school and meet some career goals before having a baby. Fortunately, as that video showed, we have more contraceptive methods available for patients to choose from. We have new delivery systems, which we're going to talk about, and we're going to talk about some of the hormonal methods and non-hormonal methods. Over the next several slides, I'll be discussing the various contraceptive options, and that will include non-hormonal options and hormonal options. Because there are so many, feel free to just click the lower right-hand corner, the icon down there, to listen to more about that option. If you are a prescriber or will be prescribing, I do recommend that you listen to all your hormonal methods. Fertility awareness methods are based on an understanding of the changes that occur throughout a woman's menstrual cycle. They require recording certain events to identify fertile days. The maximum fertility for the woman typically occurs approximately 5 days before ovulation and decreases rapidly the day after. One of these methods is the basal body temperature. This is used to detect ovulation by temperature changes during the menstrual cycle. It'll require the woman to take her temperature every morning before or upon awakening, before an activity, and they record it on a graph. So it allows them, after 3 months of recording, to look back retrospectively and predict when they are going to ovulate. The method's based on the fact that the temperature almost always rises and remains elevated for several days after ovulation due to the increase in progesterone. The ovulation method, aka cervical mucus method or Billings method, this requires the woman to abstain from sexual intercourse and assess cervical mucus daily. And of course, around ovulation, it's typically that thick yolk-like discharge. The calendar rhythm method is just based on the counting of the days and predicting when you ovulate. This would have to be done with someone that has a regular cycle. The symptothermal method, this is a combination of assessments. You look at your cycle length, the frequency and timing of coitus, cervical mucus changes, any other secondary signs of ovulation such as increased libido, abdominal bloating, middle smirts, and changes in basal body temperature. Lactational amenorrhea method is based on the woman exclusively breastfeeding for the first 6 months. That means around the clock. The high levels of prolactin should prevent ovulation. If you are supplementing or skipping feedings, then a backup method should be used. Barrier methods include the condoms, diaphragm, cervical cap, vaginal sponge, and spermicides. The male condom offers a viable means of contraception when used consistently and properly. They come in latex, polyurethane, and silicone. If used correctly, they also offer protection from sexually transmitted infections. The female condom is a thin polyurethane sheath with a flexible ring at each end. And it's usually just like the male condom, designed for one-time use. And both of these can be used with a vaginal spermicide to increase the effectiveness. And then we'll talk about the other barrier methods. In addition to preventing pregnancy, condoms should be used to protect against the transmission of HIV and sexually transmitted infection. These are barrier methods that prevent the sperm from entering the vagina. They are most effective when used with the spermicide. Each year, 18 or more pregnancies do occur with typical use of these methods. This is an image of a female condom. You can see there's a flexible ring. Well, at least you can see it. You can see it at both ends. The inner ring serves to cover the cervix, whereas the outer ring comes outside the vagina and covers the base of the penis during intercourse. It is available over the counter, designed for one-time use, and can be inserted up to 8 hours prior to intercourse. In contrast to the diaphragm, the cervical cap, this can be left in place for up to 48 hours. You don't need to add a spermicide for repeated acts of intercourse. This is a latex cup-shaped device that covers the cervix, held in place by suction. The contraceptive sponge, this can be purchased over the counter. It typically ranges from $8 to $10 for a package of 3. It's basically a sponge that contains spermicide. Professional fitting is not required. Prior to insertion, the sponge needs to be moistened with water to activate the spermicide and then inserted into the vagina so that the cup side fits snugly against the cervical os. This can be worn up to 24 hours. In fact, you should leave it in place for about 6 hours after intercourse. As mentioned, spermicide can be used in conjunction with other barrier methods. It can be used alone. Of course, it's least effective. It's available in cream, jelly, foam, vaginal film, suppository, tablet, and it works by destroying the sperm by disrupting their membrane. Discussing the hormonal contraceptives, you basically have 2 options. One that's got combination estrogen and progesterone in it, and your progesterone-only options. Your combination estrogen and progesterone includes combination oral contraceptive pills, the transdermal patch like Ortho Evra, and the transvaginal ring like the NuvaRing. When compared to progesterone-only options, the estrogen and progesterone combined make for the most efficient form of contraception if used consistently. It just shows the role of progesterone and estrogen as a contraceptive. You can see the progesterone in it helps to inhibit ovulation, and then it thickens the cervical mucus to inhibit sperm activity, and then estrogen suppresses the release of FSH from the pituitary. And remember, this is for combination, so it would include the pill, the patch, and the ring. Just like all the hormonal methods, they're going to require a prescription. Combination oral contraceptive pills, the cost of these may vary. Most of the time they are covered under insurance, and they are available through the health units and Planned Parenthood, usually at minimal to no cost. If you're a prescriber, because there are so many, it can become overwhelming, but I would say you tend to stick with the same pills. And then, of course, if you're serving a lower socioeconomic population, you usually know what's on the $4 list at Walmart or Target, and that's kind of what you'll lean towards. There are different formulations, and I'll just kind of briefly tell you about these, and over the next several slides I have examples. But your monophasic, is going to be the same amount of estrogen, progesterone in every pill that's in that pack. Biphasic would be you'd have two different pill concentrations, and then triphasic is usually like the orthotricycline, which each week it changes. Monophasic extended cycle, that just means it's the same amount of estrogen, progesterone, and you're not having any hormone-free pills, so you're not having any kind of withdrawal bleed, and that would be like Librel. 3-month cyclic would be like your seasonal, where you're having a withdrawal bleed maybe every 3 months. And then your monophasic 21-7 and 24-4. Monophasic, you're going to have 21 days of estrogen, progesterone, 7 pill-free or hormone-free pills. Monophasic, 24 days of the hormone and 4 days of no hormone, and that's like your Yaz. Multiphasic, that's what comes to mind to me is the Natassia, which is basically what we call a 4-phasic pack, and it's kind of designed to mimic your own menstrual cycle. So it does have 4 different concentration or pill concentrations. There's also estrophasic, and that is like a pill that you might have a patient who has maybe some early breakthrough bleeding before their withdrawal bleed, and this involves a consistent dosing of progesterone, and it comes down on the estrogen dose towards the end. Reaction of combination estrogen progesterone options, and that again I haven't really gotten into the patch and the ring, but that does include that because it's got estrogen progesterone in it. Menstrual irregularities, particularly in the first 3 months of any method that you start, and that's important to let the patient know because it really affects compliance. So if they know that they may have some irregular bleeding those first few months, they're more likely to tolerate it. They may have breast tenderness or a mild headache or even some nausea and vomiting when initially started. Though these lower dose pills that are on the market, you don't see that as much, or patients don't complain of that as much. And these are just a list of some other ones, and I'm actually going to get into risk. So when you start looking at thromboembolic events, we will discuss that further. Oral contraceptive pills are metabolized in the GI tract and the liver. Absorption can also be affected by conditions such as vomiting and diarrhea. In the liver, estrogen and progesterone are metabolized by the cytochrome P450, which there are a lot of medications that also induce this cytochrome, such as anti-epileptics and antibiotics. Use of these with oral contraceptive pills can decrease the efficacy of the pill, leading to breakthrough bleeding or possibly pregnancy. If you have a patient who is on certain antihypertensive like ACE inhibitors, and I probably would steer away from Yasmin, because the progesterone contained in those is drospirenone, and that can increase the risk of hyperkalemia. Before I move on to discuss the patch, I just like this slide to kind of debunk some of the common myths associated with oral contraceptive pills, which I tend to hear a lot of them, like they're afraid that the pill's going to make them gain weight, and that's not true. I always tell the girls that these are a lot lower dose pills than what maybe, your grandmother used, or so you won't have that weight gain. Also, with a lot of the lower dose pills now, some women may become amenorrheic. And this is important because there are some women out there that either want or think they need monthly bleeding. And I just reassure them that it's not necessary if they are on a pill, because it's basically just keeping the lining of their uterus so thin that each month they don't have anything to shed. So it's important to address these myths with the patient. Dermal contraceptives like the Ortho Ever patch. Now remember, this is also a combination, so it's combination estrogen and progesterone. This is a patch that you apply weekly to, and they can either do their abdomen, sacral area, the back of their arm, their upper back or upper trunk. But basically they put one patch on each week for 3 weeks, and then the 4th week they don't wear one, and that's when they have the withdrawal bleeding. And it works the same way as the other combination, where it prevents ovulation, thickens cervical mucus, and thins the lining of the uterus. It's important to note that this could be less effective in women who weigh more than 198 pounds. It's important to educate the patient when applying the patch each week that they make sure they're applying it to dry skin. If they put lotion or oils on, they don't need to do that, then try to put the patch on, as it can affect the ability to adhere to the skin. Because really it should stay in place with swimming, bathing. Common side effects of the patch, they're going to be similar to the NuvaRing and the pill. You may hear of this one. I don't know if it came out a while back, that this has had a increased risk of blood clots more so than the pill. Well, that's not necessarily true, because the pill had to go through the FDA a long time ago, and even though new pills come out, they're not looking. They're looking at the dose of estrogen. Well, because this was a new delivery method, it went through before it came out. And they warn that the skin absorption of the estrogen is 60% greater than like the pill, but they did compare it to a 35 mic pill, which most of them run between 20 and 30. Now that's when it's first put on. After time, or towards the end of the week, they found that the peak blood levels of estrogen was actually 25% lower with the patch than typical birth control pills. So in essence, there's really not an increased risk of blood clots with the patch when compared to the pill. This is a low dose, sustained release combination hormonal contraceptive. So it's got both estrogen and progesterone. It's a flexible ring, like here in the picture, that's inserted vaginally, and it's left in place for 3 weeks. And the patient puts this in, and I always tell them you cannot put it in wrong because it's absorbed through the mucosa. You can use tampons with it. If you have one, like a month early or something, you get like an extra one, make sure it's stored in the refrigerator before use. As mentioned, this is inserted into the vagina and left for 3 weeks. And so the last week you don't wear one and you have a withdrawal bleed. This needs to be a patient that's comfortable with touching herself in a sense. So they have to be able to, be okay with putting in tampons or putting this ring in themselves. You have some patients you may mention that to and they're like, oh no. But the women who do use it love it. It has, of course, the same risks as other combination methods. Works the same way, except, of course, it's absorbed transvaginally and then goes into the bloodstream. It may have less androgenic effects than oral contraceptive pills. I'm not sure really about that. You may have the patient complain of like some clear vaginal discharge, which is not, it doesn't happen that often, but you need to reassure them, of course, after you rule out anything else, that is probably related to the NuvaRing. And of course, it does not prevent sexually transmitted infections. The NuvaRing may have less GI side effects than the oral contraceptive pills, and again, that's because it's not being absorbed through the GI tract. It is not necessary to remove during or before intercourse, but it can be, but not longer than 3 hours. If it does slip out, you just wash it with cool water and replace, again, if it's within the 3 hours. The cost is similar to that of the patch, and it can be used with breastfeeding. Just know that any combination methods with estrogen and progesterone are going to reduce the amount of milk, so they need to know that. So for all the combination methods like the pill, the patch, and the ring, there are benefits other than regulating your bleeding. It does help with menstrual cramps, premenstrual symptoms that are usually associated with PMS. Decreases the incidence of functional ovarian cysts. So if you've got that patient who is having cysts or even polycystic ovarian, it's going to help suppress that. It reduces the incidence of ovarian, endometrial, and colorectal cancer. And also, if you've got that patient who has acne, it typically improves acne. And that's even more so of those dysperinone-containing pills like Yaz and Yasmin, because those kind of work to bind up any excess testosterone that could cause acne. Just to mention here, contraindications of the combination methods. You don't typically prescribe to somebody who is a smoker over 35, definitely not pregnant, so that needs to be ruled out. And then any kind of undiagnosed bleeding. If they have a history of clotting disorder, and then of course you'd want to steer away from the Yasmin, Yaz, the ones with dysperinone in it, for those with renal, hepatic, or adrenal insufficiency. But I will go over a little bit of the risk later in the presentation. I like this and I use it all the time when prescribing or even refilling contraceptives, just letting them know if they have any severe abdominal pain, chest pain, head pain, blurry vision, or leg pain, that they need to quit taking the pill. And if they're going to have any kind of thrombolytic event, it's typically going to occur, they say within the first year, but more so it's going to occur in those first 4 weeks. So that's important when you're initiating it to remember that. Progestin-only options include the progesterone-only pill, injectable such as Depo-Provera, and the implant like Nexplanon. Now we'll talk about the implant under the LARCs section. But basically, you're providing high levels of progesterone to block the LH surge and suppress ovulation. Again, it's going to thicken cervical mucus, to hopefully block some sperm penetration and then alter endometrial maturation. The pill you may see commonly prescribed in the postpartum period to the mom who's breastfeeding. They take a pill every day with no hormone-free pills. It is slightly less effective. I think it's about 95% effective, and then where combination oral contraceptives are 98 to 99% effective. And typically, after about, you may see this, like I said, postpartum, but after about 6 months of breastfeeding and taking this, they may want to consider a backup. Depo-Provera, this is a long-acting progesterone, and it can be administered IM or subcutaneously, usually every 3 months. Side effects of all progesterone only include menstrual irregularities, headache, weight gain, breast tenderness, hair loss, depression. With long-term use of Depo-Provera or any of them, you have an increased risk of bone loss, so you would want to maybe be getting some bone density scans if you're keeping somebody on Depro for 10 years or whatever. So LARCs are the long-acting reversible contraceptives, or include intrauterine devices, IUDs, and the implant, and I'll talk about each one of these. The copper IUD, or the Paragard, you can see a picture right there. It's that T-shaped device that goes in the uterus. It's placed by a healthcare provider, just like the other LARCs. It's a good option for someone who can't take hormones. It is non-hormonal. It's 99% effective, and it's good for 10 years. The copper in the Paragard basically cause an inflammatory response of the endometrial lining, which can inhibit implantation. It can also work by inhibiting fertilization. It can be used as emergency contraception, which we'll talk about. And because of the inflammatory response it causes, disadvantages can be some irregular bleeding, even heavier bleeding, unpredictable bleeding, and sometimes increased vaginal discharge. Before you put these in, you're typically going to do bacterial cultures, look for any chlamydia, gonorrhea, or any kind of infection, because you certainly wouldn't want to insert it when there was an infection. It should not be used on patients with a copper allergy or Wilson's disease. Benefits is that it's non-hormonal. So if you've got that patient who can't take hormones but really does not need to be pregnant, it's a good choice for them. If they're breastfeeding, and fertility will return immediately after removal. And the people that use it again are very satisfied, so like that 95% satisfaction rate among those that use it. The other type of IUDs include the levonorgestrel intrauterine system. Rather than copper, these contain progesterone, and that works by thickening, of course, the cervical mucus, suppressing ovulation, and it atrophies the endometrium. So by doing that, the endometrium stays relatively thin, so you shouldn't have the bleeding side effects that you'd have with Paragard. In fact, the 5-year is the Mirena, and it's indicated for patients with heavy menstrual bleeding or menorrhagia. The Scala is a little bit smaller than the Mirena, and it's good for 3 years. Just like the Paragard, you would want to screen for any infections prior to insertion. Contraindications: if somebody's got a history of PID, probably wouldn't use. Definitely pregnancy is a contraindication. Undiagnosed genital bleeding, genital malignancy, or an abnormal shaped uterine cavity. Risk of insertion include uterine perforation, and again, that's going to be with the Paragard too. Infection, unnoticed expulsion, which that'd be rare if it was unnoticed, but and then of course side effects they're going to typically occur in the first 3 months, and it may be some irregular bleeding. The next few slides are kind of repetitive, so I may not comment on all of them that are talking about the Mirena and the Scala. So to comment on this slide, I already mentioned some of the risks. Ovarian cysts, I wanted to mention with the IUDs, if you've got a patient with recurrent ovarian cysts, this is not going to be, an IUD is not going to be one of your better options for them. Because with the pill or the patch or the ring with the estrogen progesterone, it kind of quiets the ovary so they don't make cysts, whereas sometimes your IUD people will continue to have cysts. And I mentioned that the first 3 months that you can have some irregular bleeding, and again, that's going to be with any contraceptive method. But you find with the Mirena over time that patients' cycles become lighter and may even stop. So there's a large number of patients you may have that don't even have periods on Mirena. And we'll talk about timing of insertion. And just a note on any IUD that I insert, I typically have them come back a month later just to check on them. And then check, verify placement. Some people actually verify placement right after they put one in with maybe ultrasound. The other LARC is the Nexplanon subdermal implant. It was approved in 2006 and called the Implanon, but they came out later with what we call the Nexplanon, which had a device that made it a little bit easier to insert and made it radiopaque so it could be detected. It's a progesterone-only option. It's good for 3 years. Of course, it's placed by the healthcare provider. It's 99.8% effective. And one of the main side effects may be some irregular, unpredictable spotting. This is a good option for adolescents, for people that can't remember to take a pill every day. It can be used in breastfeeding, and it can be an ideal option for somebody who can't take estrogen. It is convenient, and fertility does return immediately. And I've actually had patients who got pregnant the week I took one out. So IUDs were initially indicated for only women who had had a baby and women who were in stable monogamous relationships. However, they found that LARCs, like the implant and IUDs, are appropriate choices for adolescents. Data has shown that they're not, insertion is not, much difficult on someone who has not had babies. And you don't have that high risk of infection ascending into the pelvis like we originally thought. Of course, we still recommend screening for STDs before insertion. And another reason they're good for adolescents because they don't have to remember to take a pill every day. So efficacy is not dependent on the user. They can help with dysmenorrhea and menorrhagia, which is common in adolescents. Emergency contraception, there are two forms available in the U.S. currently, the IUD, the copper IUD, or emergency contraceptive pills. The effectiveness of the methods varies based on really the method and the timing of the administration. The three types of emergency contraceptive pills that are available include combination estrogen and progesterone in 2 doses. It's also known as the UPC regimen. There's also the levonorgestrel, which is administered in a split dose, 1.5 milligrams, and that's like the Plan B that you've heard of. And then there's UPA or ELA, which is a 30 microgram pill. The recommendation timing for emergency contraception, whether it's an IUD or the pills, is that it has to be within 5 days of unprotected intercourse. Depending on when it's initiated, basically the mechanism of action can be to inhibit ovulation, or if ovulation's already occurred, then it would be inhibit fertilization versus implantation. So as a prescriber, you need to know the mechanism of action that is potentially, depending on where you define where life begins, fertilization, implantation, but know that that's a possibility, and the patient needs to know. For the emergency contraceptive pills, you can get them over the counter in Louisiana if you're over 18. If you are less than 18, it requires a prescription. And again, this varies from state to state. This website provided here is a good up-to-date information on emergency contraception and just the different state regulations. Permanent sterilization includes for the female a salpingectomy, which is cutting, burning, or blocking of the fallopian tube to prevent the ovum from being fertilized by the sperm. It's usually done laparoscopically, can be done, after a C-section. Esher tubal is another option, and this is done under hysteroscopy, and a micro insert is placed into each fallopian tube, and then over time, basically the tubes kind of scar over that to prevent fertilization. It is required, they come back for a hysterosalpingogram to visualize the micro inserts and confirm that there's been occlusion of the tubes. And to note, if they're allergic to nickel, this is not an option for them because their micro inserts are made of nickel. Male permanent sterilization includes a vasectomy, and this is cutting of the vas deferens as a form of permanent sterilization. An alternate form is needed for at least 4 to 6 weeks to allow all the sperm to clear the vas deferens post-procedure, and then they usually recheck in 6 to 12 months. So you're probably officially overwhelmed with all the options and information surrounding contraception. I hope over this next couple sections that I can give you some tips on initiating and managing your patients. When first considering the options available, you need to work with the patient and our couple in choosing the most safe, effective, affordable, and acceptable method for them. Patients may present with a certain option in mind, maybe something that their sister or their friend uses that they like, or maybe they've heard about one that that they don't like, or so and so had this happen when she used that, and Maybe they saw it on a commercial like 1-800-BAD-DRUG. So they may come in with some preconceived notions. Always ask right off, what have you used in the past? And then was it a method, why did they stop using it, or did they like it? A lot of times when you're trying to decide on the pills, if they've used something and been happy with it in the past, I tend to go back to those. You want to look at the patient's health when determining the safety. Are they in a monogamous relationship? What are their plans for fertility? Are they wanting to get pregnant in 6 months? The cost, the efficacy, and then the ease of use. You want it to be convenient for them. If it's somebody that has a crazy schedule and does something different every day, then they're probably not going to remember to take a pill every day. So what's going to matter most after you determine that the device is safe for them is correct and consistent use. Pregnancy must be ruled out prior to any contraceptive initiation. A detailed history will provide the most accurate assessment of a pregnancy risk. The CDC does offer up this criteria, and the UPT can be used in addition to this criteria, but of course there are limitations associated with the UPT. But a healthcare provider can be reasonably certain that a woman is not pregnant if she has had no signs or symptoms of pregnancy and meets one of those criteria. Now, some of those are going to be dependent upon a normal menstrual cycle. So, of course, the patient has to have normal cyclic menses. But if they do meet one of these criteria, then don't let that be a barrier to initiating. Although most contraceptive methods are safe, even for most women, there are certain health considerations when choosing the most appropriate method. To classify risks associated with the various contraceptive methods, in 1996, the World Health Organization published the first edition of the medical eligibility criteria. They used these 4 categories to classify risks as related to the methods, with one being like no restriction of use. It would be an ideal contraceptive method for this patient, to 4, and don't use that method with this patient with that condition. Building on the WHO's risk categories, the CDC created the medical eligibility criteria for contraceptive use in 2010. Their latest publication is 2016. The target audience is healthcare providers, particularly ones that counsel patients, women, and couples about contraceptive method choices. This is an evidence-based source of clinical guidance for the use of contraceptive methods by women and men with various characteristics and medical conditions. The U.S. MEC has a companion document, which is the U.S. Selected Practice Recommendations for Contraceptive Use, and its most recent publication is 2016. And this provides a little bit more detailed information on just the contraceptive method and uses and timing, initiation. But both of these resources are available through the CDC website. I've actually tacked on to the end of this presentation how to access their resources. They have so many, including apps. In fact, I keep the US MEC app on my phone just to have and use when prescribing contraception for maybe patients with comorbid conditions. So utilizing the MEC, you can look up either a condition or a certain method, and then it gives you the risk category. And this is just an example of, smoking being the condition, and then the different contraceptive options. And you see in the first column is the copper IUD, and then the second one is the Mirena and Skyla, then implants, Depo, progesterone-only pills, and combination hormonal contraceptives. So they just combine the patch, the pill and the ring in that category. And so you can see with smoking over 35, any of the combination is going to be a level 3 risk. And if they're smoking more than 15 cigarettes a day, it's a level 4. These next few slides I had and just wanted to point out, the risk category 2 is where you may use the method, but you might want to follow, have a close follow-up, because this is basically where the advantages outweigh the risk. And then I gave an example for like non-insulin dependent diabetes and known hyperlipidemias will typically fall under like category 2, just to kind of give you an example. And it may be 1 for just the copper IUD. So the risk category 3, that's really only going to be when you've exhausted all other options, and basically it'd be way worse for them to get pregnant. So this is where the risks outweigh the benefits. If you do that, it needs to be a close follow-up. And of course, you're going to take into consideration the severity of the condition, and then just if there's availability of other methods, and the patient will need to be counseled at length. So an example of this would be like chronic hypertension with combination estrogen progesterone options. Just the fact that she's got chronic hypertension, whether it's even if it's adequately managed, those patients are at increased risk for a cardiovascular event. So category 4, you just don't use that method with those. For an example, estrogen progesterone options should not be used with a history of DVT or pulmonary embolus, any kind of bleeding or clotting disorders such as the antiphospholipid syndrome. And then there's also some thrombogenic mutations like protein S, protein C, factor V, and then lupus. So if you've got somebody with lupus, do not use the estrogen progesterone options. But if you, again, look at the end of the presentation and show you how to access, maybe download the app. And I strongly recommend that you do that and kind of play around with that and just see. It's just got so much information, and it even offers the latest evidence to support it. Patients with these conditions listed here, you would probably want to have them on some type of contraception because this is the list by the MEC that these are conditions that could be worsened if an unintended pregnancy occurred. Also put out by the CDC is the efficacy of the different methods. You can see the most effective are the IUDs and the implants, followed by the moderately effective, which is like injection, combined hormonal methods, and then the least effective would be your barrier methods. So here's just another slide on some risks associated with the hormone contraceptives, and just gives you a few statistics. So you can see the risk for thromboembolus, and most contraceptives is 4 in 10,000, a little bit more in the drospirenone-containing pills, which is like the Yaz or Yasmin. And then we already discussed the greatest risk in the first year, but the definite greatest risk the first 4 weeks of use and 2 weeks after any major surgery. So this is so important. What can we communicate to our patients about safety? Well, it's so important that you educate them. Don't assume that they know, even if they've used the pill before. You need to educate and document that you educated them on the typical side effects, when to start the contraception, any risks or benefits, or even the warning signs associated with use. We already talked about the risk of using contraception with pregnancy risk. You want to make sure you get a good assessment and rule out pregnancy. Make sure you emphasize that these don't protect from sexually transmitted infections. Use language that's appropriate for the patient and answer questions truthfully. And give them, I would say, give them the evidence that supports what you're saying. These next 2 slides just kind of cover some danger, side effects, and benefits that you can make sure that you educate the patients about. Some special considerations with adolescents: you want to make sure that they've had menstrual cycles for at least a year prior to starting them on anything. We've already mentioned that LARCs are a good option. Perimenopause, you can pretty much continue. If you're on a method, you can use it all the way through menopause. Breastfeeding, you want to not start anything for at least the first 21 days. And then if they're breastfeeding, you want to avoid the combined estrogen and progesterone, just for, risk of decreasing the milk supply. Now, if they were starting to wean and that didn't matter, then you could definitely have that as an option. And then you want to consider women with headaches or migraines, and then maybe like borderline, hypertension, that there's a potential that when you prescribe, the hormones, that could worsen those. So you want to make sure you follow up closely with those. So I think that's it. The last part of the presentation are just some slides that show you how to access the resources. Thank you.